Hi, we're here today with Dr. Stacey Reynolds, the Associate Professor in the Department of Occupational Therapy at Virginia Commonwealth University. Welcome. We're going to talk a little bit about what the literature says about dosage for interventions for individuals with sensory processing and integration challenges related to concepts of intensity, duration, and frequency. And this is a topic that is near and dear to my heart because I think we don't have great answers. We have feelings about it, and we have restrictions or limitations that are imposed on us. But I'm really interested in what you feel about the state of evidence related to this topic. But first and foremost, just tell us a little bit about yourself, Dr. Reynolds.
Hi, yeah, thanks for having me, Sarah. Well, first, I'm an occupational therapist. I've been an OT for 20 years or more. And I've always practiced in pediatrics, and pretty early on in my career, I got my certification in sensory integration and have focused not only my clinical work, but my research and teaching in the area of pediatrics and sensory processing as well. Like you said, I am currently at Virginia Commonwealth University, and I run a research lab there called the Sensory Processing and Stress Evaluation Lab. And I teach courses in pediatrics and neuroscience and things like research and grant writing. So I do a little bit of everything, but I love everything that I do, so it's great.
Would you just mention a little bit about your postdoc that you did, your K Award, because I think that was a really interesting topic that you bring to your work.
Yeah, it was a great opportunity. So at first I did my PhD with Shelley Lane at VCU and focused my research there doing human studies, measuring electrophysiological variables related to sympathetic and parasympathetic nervous system activity. And after graduating, I started a faculty position, but wanted additional training to help me really be able to look at sensory processing from a new angle or a different angle in a way that wasn't already being done. And so I applied to the K-12 Scholars Program that at the time was a joint initiative between University of Florida and UTMB. And I went to the University of Florida to train in a basic science lab in the area of behavioral neuroscience. And so I took a lot of the stuff that I had done with Shelley with children, with humans, and was able to look at that in a slightly different way by developing animal models, rodent models of sensory processing disorder. And of course, studying things in animals, you're allowed to do things at the end of a study, like take out their brain and actually look at anatomy. You can't do that with kids. So yeah, it was a great experience. And I think I learned a lot, but I think it was also a unique contribution to the literature because, again, there are only a handful of OTs who are doing that type of basic science research. And I would love to see more people doing it because it's fascinating and it adds a lot to our knowledge base of the disorder.
Well, I'm already thinking of a follow-up talk with you, conversation that we can direct towards what your findings were and how you think it informs the clinical world that people most often are functioning in. So that'll be number 2. Okay.
Part 2.
Exactly. But today, maybe you can talk a little bit about the evidence that's out there regarding dosage at this point in time.
Yeah, so this idea of dosage has started coming up a lot in conversations I was having with people, not only researchers who were starting to do clinical trials projects, but clinicians. And I saw there were clinics, hospital systems near us that began to talk about intensive dosing models. And I think first and foremost, I had to educate myself about what dosage really meant. And we think about dosage in terms of frequency or how often, the number of occurrences within a period of time. So are we talking about one time a week or 2 times a week or 3 times a week, or even within a day? Is somebody getting 2 sessions a day? So there's that frequency piece. And then there's this duration concept of, are we going to be in therapy for 2 months? Are we going to be in therapy for 2 years or 20 years? You know, we treat these kids that, you know, we call them lifers, but they're coming once a week and there's not really a stop point to it. And then there's this concept of intensity. So how long are those sessions lasting? And that plays into that whole kind of concept of a dose or in basic science, we talk about a dose response curve. You know, if you're talking about drugs, like how much is it to see an effect? And so, you know, I love this concept of thinking of what goes into dosage and what do we need to see an effect in intervention. And yeah, and as you know, most of the studies that we have supporting sensory integration intervention have used an intensive dosing model where they see a child for, you know, maybe 10 weeks or 15 weeks, and they see them 2 or 3 times a week, and that is the dose. And unfortunately, I mean, that's great research, but it hasn't translated to the clinic yet. For most clinics, I don't think have been able to adopt that model. And so we have an evidence base, but it's hard to extrapolate when we're not doing that same model in practice. So it's hard for us to say, we know this works in this format, but do we know that it works in other formats as well?
Right. And that's always been the challenge for me when we teach at STAR. Our model is one that is high frequency and short duration. Our
Right.
sessions are probably, in terms of intensity, pretty consistent across most clinics, at least that sort of 50-minute hour or 60-minute
Right.
hour. You know, I came from a traditional medical model, and, you know, like you said, we saw kids once a week for years and years and years. And when I, you know, moved to Colorado and started at STAR, I was really impressed with the type of gains that can be made in this intensive type of situation. And I feel like there are insurance companies, even in school-based practice, which is a whole other conversation probably that we could have, that there's a lot of education that we need to do as clinicians to be able to show what is possible in that intensity. I mean, I realize that there are challenges, and I want to go on to talk about that, but I also think as occupational therapists, we have a responsibility to documenting the quality and the quantity of changes that are possible within that framework.
Right.
So given that we do have these kinds of constraints, what do we do with this data, and how do we translate it into practice for clinicians? Or maybe what studies do we need to do to compare what is possible once a week versus 3 times a week? Because as you said, we don't know necessarily what's better.
Right. Yeah. I mean, so one of the challenges that I see is that, you know, we've worked really hard, and I say we, this isn't actually my own research, so I'm going to credit, you know, your team at STAR, Roseanne Schaff, Beth Pfeiffer, who have done some of these RCTs. But you do a big clinical trial, and you obviously, these are expensive to do, they're time consuming to do, and oftentimes you're only going to really be able to answer like one research question. You know, you're going to say, does this work in comparison to this? And from a dosage standpoint, you want to make sure you're giving enough of a dose that you're going to see an effect within that period of time. So it makes sense that all of these studies have used a high dosage model. But I think that we do need research where we look at different dosages and we do some dose response analyses to see at what point do we start to see effects and at what point do we start to see a plateau. And I don't think we have the data to back up that one model is necessarily better, or that model is better for every child in every situation. A lot of our SI research in general has been done on kids with autism, and I don't think we have as much research to back up how it works with kids with DCD, what it looks like in kids with genetic disorders, or how does it differ between kids that are high on the spectrum versus low on the spectrum. So in my mind, what I would like to see are really high quality small N designs that aren't as expensive as these big clinical trials, where we can have, some things stay stable, like the same intervention, the same fidelity tools, the same measurements, but that we alter the dosage within these small N designs. And we can begin to, without a huge amount of funding, begin to answer some of these questions and look at these trends. That's one approach, and that's kind of where my brain is right now. I'm sure other people have other ideas, but I'd love to see people start asking this question and trying different ways to approach it.
Yeah, that was, your brain went exactly to where I was thinking, is if you could implement a single subject study within which the child starts maybe with the once a week model. I guess what I wonder about that is, how do you deal with the fact that the child's already had some foundation of therapy? I guess you can do an alternating design, so some kids start with the 3 times a week and then go to once a week. But you can't take away the effects of whatever happens in that first stage, right?
Right.
But
Yeah.
what do you think though that clinicians could do just in their own practice to either kind of answer one of those questions, or to I don't know, to see what's possible with different, not as a research project, but just as their own clinical investigation of, maybe I have a family that is willing to try this 2 or 3 times a week, to kind of provide information to an insurance company or to a pediatrician that they're wanting to refer clients for a higher dosage intervention.
Well, I think that most of the outpatient clinics that I know of are going to have to kind of first look at, feasibility of this high dosage model within their practice area. So, if I was interested in doing this, or I thought this was a good fit for a family, I might first think through some of the pragmatics of, does our clinic have adequate space and clinic slots available? We all know those like 4:00 on a Tuesday slots are like coveted, and families might have to be more flexible. They're not going to get 4:00 slots, or 3-4 o'clock slots in a week, probably. So I think there's some of those pragmatics that people might want to think through before initiating this. So things like space and time and scheduling, and that insurance piece, right, is, if insurance is only going to cover so many visits, there's this process, this discussion that you need to have with the families and with the insurance to talk about what this model would look like for them. And I think it's different for every insurance company. Some set a limit, some say if you show progress, then you get more visits. And so I think that there is nice research out there to say that we can be pretty sure we're going to see progress with this intensive burst, that it's not, for most kids, a 30 session dose of high intensity therapy is, you're going to see progress. But I do think there's those pragmatics that clinicians and their support system, their administrators and staff and everything, need to discuss before doing this, because it is different than what we're used to, and there are challenges associated with it.
Yeah, I think so. And I remember, one time when you and I were talking about this, that some of the other logistics of, can a family with possibly three or two or three other children be
Right.
able to get to appointments that regularly? And now with the advent of, some telehealth measures, it might actually
Hmm.
allow for more um, variability in how we schedule that frequency of intervention. Um, and also, as you were talking, I was two things I wanted to bring up, because I think having that dosage model, let's say, doesn't mean that after whatever 3 or 4 months that the child has to be discontinued, or
Correct.
that they can't take a break and have another burst down the
Mhm.
road, especially when there are a lot of new developmental challenges that are presenting themselves. But that documenting the changes that have occurred, I think is really important, and many clinics do post testing, but many clinics don't. And, having maybe something like goal attainment scaling as an
Right.
individualized mechanism to be able to convey what outcomes were possible during that period of time, or possibly why continued intervention might be necessary because maybe the goals weren't attained.
Absolutely. Yeah. And that was kind of my next thought, was that then if people proceed with this, then data collection is essential. And I totally agree. Goal attainment scaling, I think from the very beginning, you're sitting down with clients and their families and you're saying, what are your priorities? What are the top things you want to work on? And at the end of this, what do you want to be able to do? And and letting that guide your treatment plans. Because by focusing on those goals, I think it gives everybody that motivation, like we're in it together. This is the time that we have to work on it. We're going to prioritize this in our lives. Um, but it's not only the pre and post testing, that because you have such a short, if you're doing a short duration of, 15 weeks, 10 weeks, then you can't get 3 or 4 weeks into it and realize that the child's not progressing. So I think data collection throughout really needs to be a formative process. So having some way to kind of check in at the end of every week and say, are we making progress towards this goal? If we're not, what do I need to change? Does my plan need to change? Does our approach need to change? Do we need to build something different in? Otherwise, there is that risk that you get to the end of if you just rely on pre and post tests, then you get to the end of that 15 weeks and you're like, man, that didn't go the way I wanted to. And
Right.
I think as therapists, we do this, we're always kind of checking in our own heads, but there really is value to collecting hard data throughout. So, whether it's something like jumping jacks or functional, like assist level for toothbrushing, to kind of check in on that on a really regular basis is important.
I totally agree with you. I mean, I think it is part of the clinical reasoning process that
Mhm.
therapists use somehow intuitively throughout their treatment, but concretizing it with some kind of measure that you check in with, or a couple, because you may hypothesize that toothbrushing maybe is going to improve, but maybe it's hairbrushing, or some kind of motor skill you might think would be balance and balance related, but actually it's more coordination related.
Right.
And I think that's, at least in our research, one of the biggest challenges is finding what that measure is that we could look at repeatedly.
Yeah. And that, we just finished, as working on a multiple baseline design. And one of our outcomes, or one of the things that we figured out, was that maybe we didn't pick all of the right measures. Some of them were good, but if we were going to do it again, 1 foot balance was really hard to measure change with. And I think that's because balance is related to not just the vestibular system, but or the sensory systems in general, but balance is impacted by attention, balance is impacted by arousal. And it just wasn't a real stable measure to show change. And so I think we learned some of these things through trial and error, and it's really important to try and publish those so that other people learn from your mistakes and, can progress forward with it.
Yeah, well, it's funny that you mentioned that about balance, because I was just thinking, because we had a paper that we published recently on a group with kids who were on trampolines. So it was a therapy group working on social interaction and motor skills at the same time. And we also had 1 foot balance as an outcome, a repeated measure also throughout the group. And it didn't show any change. And I attributed it to the fact that I think a lot of the motor work we do with kids is actually more dynamic in nature. So a static 1 foot task maybe isn't reflecting actually what the underlying mechanisms are that were impacting relative to more of a dynamic flow of movement abilities. But
you should test that theory, Sarah.
I'm sorry, test that theory.
Test that, yeah.
Well, then I have to come up with a good dynamic balance task. I have to figure out what that one is. Maybe walking a line, I don't know.
Yeah.
Has some possibilities. But I want to thank you. This has been so much fun to talk to you about this. And I have a sense that maybe somewhere down the line we could design a study together.
Ooh, that would be fun.
Implement it at 2 sites even.
Yeah.
See what kind of outcomes we could generate. So again, I want to thank you so much for your time today, and I look forward to talking to you in the near future.
Great, Sarah. Thank you.